Hi everyone, Katie Bell here. Most of you know me as the TA for Telewell for developing medication-assisted treatment programs in our tribal and our urban Indian health clinics. Jeff asked me to step in with a webinar, and here is what I consider to be 3 essentials for a best practice multidisciplinary program. Next slide. So we're going to identify 3 key ways to improve patient stabilization, understand the value of interdisciplinary collaboration, and name 2 ways to build structure for MAT programs. Next. One of the essential, actually, I consider this more and more essential, especially as I travel to clinics and watch them struggle with working together as a team. The weekly case reviews are useful in many ways, but it really contributes to best practice patient stabilization. This is the time that we sit, in our case, it's the RN and the LMFT assigned to our MAT program and our provider. We move pretty quickly. We usually address the needs of about 35 patients in under an hour, and we build it into our staff schedules. So the clinic becomes accustomed to the utilization of our provider's time in our clinic. We actually bill for that provider time to one of our grants, and very essential. And what we do is we go over each and every patient in our clinic. We use the phases of care, and we'll talk about that in a little bit. The case reviews are led by 1 team member. In our case, it's the RN. And so I keep the conversation very disciplined and focused on the care of the patient, the current status of the patient, and their level of care needs. I prepare for this by knowing as much as I can, but also knowing things like their recent urine drug results, their case management needs. Do they have medical issues that are being addressed? Behavioral health issues, are they homeless, are they finding shelter, are they going into treatment? All those things are essential topics for each patient. Next slide. So I use a roster. I have developed a roster that I've been using over the years where all of our current active MAT patients are easy to see. We update it weekly. That includes updating their dosing, their phases, maybe where we can find them for some reason, that maybe they're in a different setting than their home setting. The purpose of case review is to check in on everybody, but some of our patients will be stable and not require discussion. However, we go through each patient, we name each patient in case maybe the doctor saw them or the behavioral health person saw them and they have some information that the team does not have. So the purpose is to really loop everybody in on every patient very efficiently and purposefully. So next one. Let me see. So as those of us that work with patients with opiate use disorder and they're coming in for treatment with medication-assisted treatment, we understand the complexity of their needs, and the focus is on stabilization, especially in the first few months that the patient is under a care. It's very important that all of their case management and medical and behavioral health and addiction needs are met. So so we start with, this is essential number 2, it's phases of care. Some clinics call it tiered care, but basically it's the same approach of seeing our patients more frequently, and as they stabilize, seeing them less frequently. It's kind of basic. So we always start with the buprenorphine ASAP. And by that, I mean, if the patient comes in and we've identified them as being a good candidate for a program, usually there are very few reasons why they are not. Might be an insurance glitch or something, but our first goal is to stop the use of opioids as soon as possible. So if a patient walks in and they're in withdrawal, we're going to make sure that we get them comfortable before we start all the paperwork. If they're already on using Suboxone, often they come in and they are already have started self-treating with buprenorphine. And so that's always what we do first, is we want to stop the use of the opioid and start the medical care with the buprenorphine treatment. We find the best possible dose to manage cravings. This is, for example, if we have a patient that comes in and they are in withdrawal, or they're doing a home induction where they're going to have to go through a withdrawal phase, the focus is on getting the patient as comfortable as possible, as quickly as possible. So this means monitoring their bup start. We used to call them inductions, but we call them buprenorphine starts now, or starting buprenorphine. That is, it's essential if the patient is still craving, that we work with the doctor in supporting getting the dose up to a comfort level for them. Once the withdrawal is well managed, then we can begin to take the next few weeks to discover best possible dose for the patient, and we call that the sweet spot. No cravings, no withdrawal breaking through, and minimal side effects. So the first few weeks are all about that aspect of care, and it's really helpful to have an RN kind of oversee that. The phases of care are clearly defined requirements. By that I mean when the patient signs on to our program, they sign a treatment agreement. It's kind of a common sense document, but it provides some early structure which contributes to the stabilization. And we'll talk about that in a little bit. So phase one is basically seeing our patients for weekly group visits. That's what I just did this morning. I came from a group visit with brief face-to-face with provider. Our provider sees them very briefly and quickly in the time before group starts. So it's from 9:30 to 10 on Wednesdays in our case. 7-day buprenorphine script, weekly urine drug screens, and required behavioral health biopsychosocial within 30 days. So that's our phase one. Lots of monitoring, lots of follow-up, lots of group activity and behavioral health. Next. So the next phase of care, phase two, our clinic, we started out with a nurse and a provider, so we have kept it very efficient. Now we have a bigger team. We have a behavioral health person on our team. Phase two progresses to 2-week visits, 2-week drug screens, 2-week buprenorphine refills. And when a patient moves from phase one to phase two, we meet with them and we update the treatment recovery plan. When a patient moves from phase one to phase two is entirely patient-centered. Our phase one and phase two is what we call a harm reduction and abstinence-directed phase. So if we have patients that are still testing positive for methamphetamines, for example, they will remain in phase one. The requirement is for consecutive appropriate urine drug screens, which means positive for bup only, or we usually don't die on the cannabis hill unless we really feel that it's a problem for the patient. But Different clinics have different approaches and different providers do. And we can talk about that later if you'd like. But definitely 4 consecutive appropriate urine drug screens is one of the minimum requirements. Also that they have completed their behavioral health biopsychosocial visit, and that their buprenorphine naloxone dose is stable. So no changing around. And then we go to phase 2. And phase 3 is progressing out to monthly visits. And so we see them every month, and monthly urine drug screens. We have it set up so that if you're coming into the clinic to pick up your refill, whether it's 7 days, 14 days, or 30 days, the urine drug screen is submitted at that time. So we tie those requirements together, so it's patient's convenience is part of it. With every change, we update the recovery plan, and at the beginning, our patients fully understand that if they struggle, have a relapse, require more support, that we will bring them back to the level of care that we think will be most appropriate for restabilizing them. So we don't make a big deal about, now you've graduated to phase 3, because we understand the nature of addiction, that we're dealing with frequent relapse. And it's more about, we want to see you more, we want to support you more, we are intensifying care. And if a patient has had a relapse and they are working, we're going to have to adapt. Maybe we won't have them come back to weekly groups, but we'll be seeing them every week. And once stable, we return them to the appropriate phase of care. So it's a very simple tiered thing. The patients understand it. It's part of our intake process to really go over this with them. So there's no questions. And when we update their treatment plan, we really emphasize the required behaviors. Like sometimes we'll talk about phase 3 behaviors. So phase 3 behaviors is you take care of your appointments, you call us, you do the scheduling. So if they disappear, they stop calling, we'll say, well, that wasn't a phase 3 behavior. Next. So essential number 3 is structure. And everybody uses some kind of informed consent for buprenorphine, and treatment agreements and recovery treatment plans. We have developed this into one document. And so it gives us the opportunity to really discuss buprenorphine very thoroughly in terms of the medication as a treatment. Also the requirements, our requirements are pretty easy to meet, and we always have patient-centered flexibility, but we have certain things that we really do require, which is to have urine drug screens, which gives the provider a sense of whether they're prescribing safely. We are not legalistic around our treatment agreement. It's about supporting best possible outcomes for our patients. And spending time with the treatment agreement really gives them a sense of what is expected and areas where they might need some flexible support. Recovery treatment plan is often a simple thing. Phase 1, we're going to see you every week. You're going to make your behavioral health appointment and go from there. If you decide you want to continue in therapy, that gets determined in that meeting. Also, our patients, some of them are intensive outpatient or outpatient settings, going to NA or AA. We build all of their preferences into our recovery treatment plan. And if a patient begins to drift a little bit, or maybe not fulfilling the requirements, I will just invite them to come in. Let's go over your treatment agreement and see if there's something that we've missed here, something we need to change together. I use this treatment agreement as an interventional tool. So gotta have it in my program. Next. So the other aspect of structure that is very helpful, a lot of clinics are adopting this or have been doing it already. We call them refill stabilization groups. Some people call them MAT groups. But the refill stabilization group really communicates to the patient and to our clinic what this group is about. And I just finished up with a group. It's really a wonderful time for group support, face-to-face provider time, and developing recovery tools. The billable provider time with the group visit, we bill for a face-to-face visit. We actually have the patient meeting with the doctor behind a screen in our group room, and we protect confidentiality by playing music and being in a distance. So those encounters are brief. It's usually focused on dose, cravings, identifying any primary care needs, and we will get them seen by their primary care provider. So it's not a primary care visit. By having a patient come in once a week, it's pretty convenient for our patients. And sometimes they need to establish some travel support with the managed care plans, or we'll work on getting them there at all possible costs. We always have gas cards and bus tickets on hand, so coming to group is considered to be very important, and our patients love and look forward to the experience. Team-based care, we are all in the room. The provider, the nurse case manager, and the LMFT are all part of this group visit, and we do many different things depending on who's leading the group. Today we did a process around the return of the felt experience after discontinuing the use of full agonist opioids. Next slide. Is that it? End of slideshow?
End of slideshow.
All right, so I covered a lot of material pretty quickly, and I would love to hear any questions or any thoughts or any arguments. Any arguments, Jeff? So can everybody, let's hear. Oh, also, I have handouts, our treatment plan, our recovery treatment plan, treatment agreement, informed consent document, our case review guidelines, and a paper on our refill stabilization groups are all available to attendees. Any questions?
So if anyone has a question, feel free to either chat or raise the hand, and I will go ahead and unmute the microphone. Let's see, we do have a couple. So one of the attendees says, I'm a little confused about the MAT group. Who is behind a screen? Do you bill for each patient?
Yes. Okay. Yeah, that is, well, so we struggled for a while about how to bill for the visit, and we adopted something called centering. The centering process, which was developed for treating prenatal patients or perinatal patients, pregnant mothers, and then after delivery, meeting in a group setting. And their technique is to create a place in the room that's completely protected. So we have a folding screen, and the doctor's set up with a desk, and they have their laptop. It's comfortable, it's not cramped. And during the time that the doctor is in the room, we are not doing any educational recovery tools. It's a social time. So, and we have music going, so that kind of creates, it very effectively creates confidentiality. And so we have, while the social time is going on, the doctor sees a patient for a quick face-to-face, and we bill a 99212 with that. Part of the group visit is when the patient first comes in, they do a self-report on the cravings, side effects, anxiety, depression, other things, what they did for recovery, if they need to see a doctor. That goes to our medical assistant, who then does the vitals, which are part of the visit, and the urine drug screens. So all those things get done in that quick visit time.
Okay. So the next question is, let's see. I would love the link for that information, please. Absolutely. I will send that out following this this webinar. In addition to that, I will also send a survey, and if everyone could take the time to fill that out, that would be greatly appreciated. Let's see, Melinda also said, so they see the MA for vitals, get UDS, then see the doctor one at a time behind the screen while the group is going on.
Yep, that's how we do it. So we have a very clear flow of patients. And we have, like, I will manage that in terms of keeping the patients pointed in the right direction. And then our LMFT will be spending time with the patients. So usually we have one person who's managing patient flow. It's very efficient. It works well for about a group of up to 12. And everybody really likes this. Is your roster online too? Hi, Iris. I don't know if the roster is online, but I would love to send you a copy.
Oh, is your roster an online tool?
Oh, okay. So the roster was something that I developed with, actually the psychiatrist I was working with at the VA developed it for me. And so it's a nurse's worksheet that has many uses in terms of keeping track of patients, identifying lengths of stay, stabilization. If you would like to take a look at it, I'd be happy to email it to you. We keep it, it is an Excel tool, and we keep it protected, password protected. So it's really useful. A lot of, I've shared it with many people and they like it.
Michael says, I am new to MAT TOR program and would love to come and visit an active up and running MAT TOR program to see how they are doing things currently.
Yeah, we can see if we can set that up for you, Michael. I'm actually leaving Chapaday, but there are many clinics do site visits, so I'll be happy to do that. Let's talk offline. We'll get that to happen.
And Melinda says, how long do you meet with 12 patients?
So we set aside 9:30 to 12 for our program. It used to be 10 to 12, and then when we started doing the doctor visits within the room, we start early. Usually the provider's there about 9:30. So it takes, the group itself is an hour. The group is an hour. If you'd like me to tell you a little bit more what our curriculum looks like, I'd be happy to do it. We have a format, very specific format that we use for our groups.
And we have a question, what day works best for this clinic?
Good question. I kind of like Wednesday morning. And the reason is that often we'll start patients on their buprenorphine at the very beginning of the week. And it gives us a chance to, and that's exactly what we did this week with a new patient. They were started on Monday and they were sitting in group, comfortable and connecting with the other members of the group today, Wednesday morning. Also gives us a chance if there are any kind of adjustments that need to be made. That gives us a little more time in the clinic week to get them in to be seen if that's the need. So midweek is a good time. Some people do it on Thursday or Tuesday.
Okay, and Melinda says, I would like to see the format and any topics you cover in group.
Okay. So let me just tell you a little bit about our format, and I'll be happy to send you some samples of our curriculum. The curriculum is really developed by the team. Often we're responding to things that are coming up in group that we want to work on together. Our format is the hour that we spend together starts with 5-minute mindfulness. And then we have a period of group check-in where everybody checks in with each other. We're really very committed to our group being a safe community of recovery. A lot of our patients have known each other since they were in high school, have used together, and now they're in a recovering community. So our focus in that group is building safe community. We will then spend maybe 10 or 15 minutes on education. What is buprenorphine? How does it work? Today we talked about childhood trauma and its connection with opiate use disorder. It was a very meaningful group for our patients today. They really, they took pictures of the whiteboard, which is always a sign that something's clicking for them. So that was a brief 15-minute education. And then we go to process. We do what we call recovery tools, and we have 8 different sections that we move through, whether it's life management skills or CBT or relationships, stress management. We developed something that we felt worked for us. And I noticed that other clinics, when I visit, have done the same. They develop curriculums based on the strengths of the team and the needs of the patients.
Thank you. And we have another message. This is Karen Tooney's Pitt River Health and would like to visit. Is there training specifically for RNs to be a provider in the MAT program or other team members?
Yeah, there's lots of training out there, Karen, and I'll reach out to you via email, you and Michael, and we'll start discussing that. One of the things that am really very committed to starting in the next few months is a nurse, MAT RN nurses weekly forum so that we can all talk together about all aspects of MAT care. And often the case manager, the main case manager for an MAT program is an RN. So that's coming, and probably I'm thinking we're going to start that in early January. I will let you know. And there's lots of trainings out there, so we'll get that to you, to anybody.
Awesome. Thank you, Katie. Do we have any other questions? We'll wait here for a second to, for the questions to roll in on the chat.
So Jeff, could you put up my Telewell email address?
Absolutely, yeah.
So if other questions come up or there's links that they want, or any way that I can add support to this webinar, please reach out to me. The other thing that we can let you know is that the Telewell.org website, you can go to the Telewell Indian and Health MAT project section of that webpage, and then go to the MAT technical assistance, and there is quite a bit of material that you can access. A lot of it is stuff I briefly presented here. You can get into it in depth.
Awesome. Well, thank you very much, Katie, for this webinar. This has been very, very informative. And thank you everyone for attending.